Good morning.
Good morning, ma'am.
Okay, so we are going to do the lab. If you want, you can pull up the Word document or to fill in the blanks, and then I'll post these slides after. Again, it's not homework, it's more to be fun and challenging, maybe uncomfortable, because it's participatory, right? Some of you like doing that, others don't, but you have to get used to it. So, any questions before we start on the review, or any topics you would like? Obviously, you're not studying for it, because Paul was on Friday. So is there anything like, oh, maybe Cushing's isn't clicking, or this isn't like ACTH, I get anything. If there's any questions, let me know. Yesterday, I hijacked a counseling session, and we went through this feedback loop of Cushing's. I drew a little picture, because that makes sense to me, but if anybody wants that at the end, let me know. We'll have time, because for whatever reason, instead of 2 hours, it's 3 hours. Not sure why. Do you guys have an early lunch then?
No. We're planning 2 hours.
Oh, okay. It will be like probably the full 2.
Whatever time you need.
But anyway, I don't think I'll be very good. But if you have questions, come to me today, because I'll be at a conference the next 2 days, but available by phone. But happy to go through it. Only takes like 5 minutes. Okay, so how this works, I'm going to walk around and ask you a question. It's kind of like you guys had Irving, right? You had Irving, yeah. It's like that, but it is, you can ask a friend. Just try. I walk around, and again, these cases are harder than what you're going to get in on the test. Okay. All right, so we have Gertrude Channel, a 23-year-old female, presents with a 4-month history of increasing fatigue, but she also feels jumpy, has episodes of shortness of breath. She reports that her heart races during physical exertion, and over the past month, these symptoms have progressively worsened. She now experiences them even when climbing stairs or carrying her 2-year-old daughter. What systems do you have in your differential? So when we think systems, think like review of symptoms. Systems. So like big picture. Unless that's starting off front. Let's mix it up. Okay, so what are organ systems? What do you think, are you thinking for this person?
Thyroid?
Yeah, so what big system is that? What class is that? Yeah, endo. Perfect, right? See, it's not scary. Endo, we're in endo. Oh, look. Okay. Okay, what's another system? So they have, looking at the symptoms, like, yeah, home because of the progressively work, the climbing stairs piece, maybe? Okay. What else? Oh, what's another system? What's close to respiratory? What? Yeah, cardio. Why? Because they're feeling jumpy. Fatigue could be cardio, endo, pulm, heart racing, all of that stuff. This one's tricky. What about fatigue? What other systems do you think fatigue? You haven't had this class yet. Blood. Yeah, you can phone a friend as long as you try. What have you had, Fran, last semester, and people get tired and might feel jumpy or agitated? Yeah. I want to throw these, but I was a volleyball player, so I have really bad aim. So if you're okay with that, I can throw them. But okay, perfect. All right, so we got that. Good job. She's recently taken leave of absence from work. She works as a waitress because of her hand tremors, and it's causing her to spill coffee frequently. She reports increased irritability and has been arguing more with her husband over minor issues, including frequent disagreements about the house temperature, which she claims is always too hot. Oh, and she's lost 10 pounds despite a good appetite. So, pretty long history, right? She's telling you all these details. Then we look at her physical exam. Vitals, okay with those? Yeah, they're fine. I'm not too looked up about those. 130 doesn't scare me at all, so it's fine. But you can always compare and if you want to, but it's fine. Physical exam, so she's thin and she's fidgety. Her skin is warm with no lesions. Turgor, so she's hydrated. Her visual stuff is fine. Her neck, that's what we care about. Okay, so it's non-tender, diffusely enlarged, soft thyroid. No nodules or lymphadenopathy. and you hear a brewery on the thyroid gland. Do the heart and lungs, you notice tachy, but nothing else. Abdominal exam is fine. MSK is good, but DTR show a rapid relaxation phase bilateral on the patella. Ooh, so lots of fun physical exams, findings. So think of what this person could have. Okay, what lab do you want to order? Or what test? Well, we're going to say lab, based on all of these things. Yeah, and what do you order with T4 always, never by itself? Yes. I was going to give you this evening, but what else do you guys want to order as a group? T3, yep, because why are we thinking hyper or hypo? Hyper, right? Okay, so T3, what other labs? Think cardio, CBC, CMP, yeah, lipids, you can do the screening stuff. What about non-lab stuff? What can we order? Urine, EKG, yes, EKG for sure. Because that tachycardia, and then that can help me be like, is this like a SVT, or is it just basic tachycardia, all of that stuff. You could do a chest x-ray, I guess, but that's for Friday. If we're concerned about the thyroid and we get our labs back, we know we can do an ultrasound or the RAIU scan, right? So we have those in our back pocket. Okay. Thoughts on the tachycardia? Okay. Who wants to read this? Oh, it's blurry. Don't worry, you don't have to read it. It's Indo. But you should practice reading EKGs over and over again. But it is sinus attack. And so not worried about any, less worried about the cardiac stuff, right? Okay, what do the labs tell you? Take a second.
High T3, high T4.
That looks like pink butter.
Oh, it is right there, you're right. This is an old one. Yep, right there. Okay, so rate of attendance stack, and I'll take that out. Thank you. I just left it in from last time. Okay, good call. See? Look at you guys. You're ready for Cardio 4 right now. Have you guys done ALS and that stuff yet? Or is that just one? Okay, then you'll get that one. Okay, so we're going to do the same ones. Yeah, okay. Is she pregnant? Yeah, so we definitely want to check pregnancy always, right? Because it matters with treatment, and it matters because pregnancy does weird stuff too, right? Okay, so now what's your differential? Like specific diagnosis. We have a low TSH, a high T3, and a high T4, and she's not pregnant. What do you think? Yeah, hyperthyroidism. So specifically Graves, maybe. What are other causes of hyperthyroidism?
Thyroiditis.
Thyroiditis is that toxic multinodal goiter. Maybe like some medications can cause it, but I'm not checking on those. Okay, so for sure we're thinking Graves or some other thyroiditis. We're not worried about pregnancy. Okay, so I guess what you want. Okay, then we do a scan because we're thinking hyper. What do you see? How would you describe it? You don't have to, you're not a radiologist, but let's say the one on the right is not her, and the one on the left, that's normal, and then left. What do you envision?
Super hot. Hot nut.
Yeah, I know. So that means it's functioning more, right? It's, would you say like diffusely enlarged? Yeah, so that helps, that goes with your story, right? Good job. I'm sorry. So it's just like, yeah, I know, breakfast candy. And then, so it goes with that group. So what we talked about yesterday, would you guys think this is Graves or thyroiditis? Graves, right? So we have two reasons why it's Graves. Is the T3 is high, and then she has significant symptoms, right? She's not working because of this, right? So it's pretty significant. And then we do our lovely scan, and it's diffusely enlarged. Or with thyroiditis, it would be, we would just see one single point typically in the hyperthyroidism. Okay? What's your diagnosis? Yeah. Okay. And I know it's tough. Do you take like urine photos? You can't. You got a question. Okay. So what? No, this is easy. What are the hallmarks of this condition? So like, what what made you think Graves? We did physical exam labs, Raz already talked about the scan. This is a hallmark, but what else about this person makes you think Graves? Like symptom wise. Oh, here we go. This is her. Oh, no, that's not her. Okay. You don't even need to look the case. What are signs and symptoms of Graves or hyperthyroid when that dial goes up? Yeah, tachycardia, tremor, sweating, heat intolerance, weight loss, agitation, all of those things, right? Fatigue, but everybody has fatigue. Okay, you guys feel good with that one? All right, so she ultimately was diagnosed with hypothyroidism, treated with radioactive iodine-131 ablation, following a negative pregnancy test, and obviously she wasn't wanting to have more babies. She did that. 2 months after treatment, she's like, oh, I feel so good. I'm back to work, and things are good. However, she did not attend her follow-up appointments because her symptoms had resolved and life got busy. This is a Florida patient. My Colorado patients always followed up. They came before they needed to see me, but for whatever reason, there's something about Florida when I was there where they were just like, I'd be like, yeah, I'm like, hey, why'd you stop your meds? And they'd be like, I don't know, I just didn't decide to take my meds. So anyway, so this is realistic, not to knock on Florida people, but that's where I saw it more. All right, so we're fast forwarding 2 years from now. She had the iodine-131 treatment, and she returns with new symptoms. She reports persistent fatigue, dry skin, constipation. Her menstrual cycles have become irregular and heavier than usual. So how does her vitals look overall versus last time? Or even if you don't remember last time, what do you see on the vitals? What do you see all of that?
No longer chubby.
Yeah, she's heavier, she's 130. Her heart rate, would you say that's low?
Yep.
Yeah, and then her blood pressure, do we like that one? Not so much, right? But she's well appearing, she's not having any acute distress. You do a physical exam, it's not as exciting. All you notice is some dry skin, maybe some thinning hair. Obviously, thankfully, there's no goiter or masses anywhere on the thyroid. And then going down to DTRs, we have the opposite, delayed in relaxation phase, okay? All right, so what is the highest and easy differential? What do you think this person has? Yeah, what's it cost from? We did it, right? Right? It's easy. But we still need to do labs. So what labs should we do on this patient? What labs do you want to do on her?
Definitely TSH.
Yeah, TSH, T4. I'm just repeating it for the audio, so sorry. I hope that's everything. If I don't, just tell me and I'll continue to repeat. So TSH, T4, awesome. And then I see CDC, CMP, doing all of those. Good idea to check pregnancy tests too, right? Always. Okay. Good job. Anybody else want to order anything else? Or do you guys feel good with that? All right, so you get these labs. And take a second and look at those. What you do an EKG, sinus bradycardia, not an AV block. I would have put an EKG at this part of it. Anyway, so just normal sinus bradycardia, trust me. What do you explain those labs from? What do you see? Okay, and what's the results? It's right there.
I mean, the 3 T4.
Yeah, and what about TSH? Yeah, so, and then we'll say she's not pregnant. There was a T3, but I took that out because I don't want you to order T3. So, perfect. So, based on that, what's your primary diagnosis? Are we still thinking hypothyroidism? Yeah, right? Yeah, okay. Is this a primary or secondary reason? Where's the problem? Secondary is always pituitary. Is pituitary the problem? See how it's like so simple, but it's easy to be like, ugh. So the problem is the thyroid gland. What do you do? It's your thyroid gland. Right? So it's not pituitary, it's the primary, okay? What signs and symptoms correlate with the lab findings of high TSH and low T4? Constipation, yes. Yes, perfect. Yep, all of that. And you can see hypertension in both hyper and hypo, or see normal. But yes, so we're turning that dial down. The DTRs are different. We're the bradycardia, all of that. So different, they might struggle with celiac, they might have irregularities, menstrual irregularities, all those things, okay? Okay. Here's the answer of this patient specifically. Okay, what's the cause? We already talked about this. We did this, right? The ablation is what we did it. So how long should this person be on what med? Levothyroxine, right? How long should this person be on this medicine? Forever. Good job. I think I heard you. Yeah. Okay. So, and then how often do we monitor this person? When do you want to see him back? We're starting him on levothyroxine.
4 to 6.
How frequent? Like a day? 4 to 6 weeks? Yes, because we're starting them on levothyroxine. When do you want to see him back? Yeah, 6 to 8 weeks, perfect. And then we use what lab to determine treatment, or the dosing treatment? What lab? Well, this is my most important thyroid lab. Yes, perfect. No, I know you can talk. I've heard you. Okay. Okay, so we're gonna do 4 to 6 weeks, and TSH is our one, right? So, perfect. What is key? Okay, so we're gonna start levothyroxine. What is the key education we have to give this patient about the medicine? Okay. First thing in the morning. Who wants to help? First thing in the morning. Do I take it with vitamins and other meds? No, right? You have to educate the patient. If your patient wants to have coffee and milk first thing in the morning, they can't take it at night, but you want it at the same time each night, all of that stuff, super, super important things. Can I miss the pill? Should I miss the pill? No. It's like birth control. It's just explain. This is not like a medicine in a way. It's like something your body's already making, but it's not making enough, clearly, because we took it out. And then we want to recheck the labs every 6 to 8 weeks until they're stable, and then it extends from there, okay? What additionally should we ask this patient, not just labs? What's another thing that helps us with treatment? Labs are important. Yeah, signs and symptoms, okay? We don't go into like the cytomel treatment and stuff for people who are like controlled by labs, but just still struggle, that's more endo. But yeah, you ask them how they're doing too. Or you made it through that class, okay? You have another chance. I know you're really excited about this. Okay, we have Emma Cortisol, and she's a 35-year-old woman who presents for a routine physical exam and is found to have elevated blood pressure of 188 over 112, and her pulse is 82. Previous visits, her blood pressure has been high, 160 over 94, 158 over 92. So again, long-standing hypertension. On further questioning, the patient reports experiencing episodes approximately twice a month, characterized by sudden onset apprehension, a severe headache, lots of sweating, rapid heartbeat, pale face. They're abrupt when they start. They last 10 to 15 minutes, and then they resolve on their own. Can you diagnose her with hypertension? This isn't even endo. Based on the 3 vitals you have. What do you think? It's yes or no? Yes. Yes. Yes, with confidence. I like it. Yes, with confidence. You absolutely can. And the reason is because you have multiple high BP readings, right? And other reasons. Okay. So, what endocrine and non-endocrine causes, what are some causes of secondary hypertension as a group? What are our causes for hypertension? Hyperthyroidism, hypo, we can't even it, right? What about those cortisol ones? Yeah, Theo, perfect. What's a cortisol specific one? Talk about it. I have a moon face. I have Cushing's, right? What about I have big hands and my jaws? Acromegaly, right? Cushing disease, Cushing syndrome, acromegaly, all of these things. And then of course there's that one diagnosis that's all about hypertension. Yes, hyperaldosteronism. Great. So, and then there's all those other cardiac causes. You guys want to do those? No, you don't. But like OSA, Parkinson, all of these, there's lots of other causes, not just endo. Okay, so she's had these high blood pressures. We go ahead, your tech repeats the blood pressure and it's still high. And heart rate's roughly the same. She is not in acute distress and her physical exam is unremarkable. This patient, she had labs done before her appointment. Okay, so we can look at those. give you a second. The CDC, TSHT4, and okay. In Genesis and in Alta, the labs are always really, really small. So I'm trying to make this bigger. But, okay. Based on history, physical, initial labs, just initial labs, do we have a diagnosis? No, we need something more. Because is her thyroid fine? Yeah. Her electrolytes, what do you guys think? Look okay? Potassium, I'm gonna go straight for the potassium. Okay, it's normal. But it could be normal in all those hyperaldosterone patients. She's not anemic. Okay. So we might be thinking of a differential, but we don't have that specific diagnosis. What of the signs and symptoms lead you to think it could be excess catecholamines?
Sudden onset.
Hypermetabolic.
Very good. What do you think? What are her signs and symptoms? All right, I don't know if I have them.
Palpitations.
Oh, yeah. What are her signs and symptoms make you think excess catecholamines? What's the diagnosis with excess catecholamines? Theo, right? Yeah. So what in here, what makes you think?
Sudden onset.
Sudden onset. Yeah, there's like episodic, right? What else? So read down there at the bottom, what else? It's classic. Yeah, severe headache, the sweating, rapid heart rate, all of that. So let's go to the slide. Oh no, why is that? Oh. Here, remember this? Key symptoms, hypertension, check. Headache, check. Diaphoresis, check. Her heartbeat is racing. Not in physical exam today, it's fine. But so then there's those key symptoms plus the additional, right? So do you think we can order a FIA or those plasma-free metapherin on this person?
Yeah.
Right? Could be spontaneous, all of those things. Okay. So, what labs? What else do you want to order? I think it's 7. What else do you want to order? The CBC is catecholamines, right? Yeah. So that's a blood test. We can do that. We have the CBC. We did the thyroid. We have the CMP. This is a little tricky. I would say less than 4 on this because we already did that. But what's a lab that you do on any female?
HCG.
HCG, yeah. So, okay. Now let's get the labs. It's small. We have metapherin, norepinephrine, and noradrenaline. If it's high or low, they're high. And then we get the full CMP there. And it looks okay. Her urinalysis is okay. Okay. So this one is a tricky harder. Okay. What lab? So we have elevated plasma metapherin. What lab is used to confirm it? We have to. Yes, perfect. Urine helps in a lot of things. So the 24-hour urine for fractionated metapherin is a long one. And you get that. And it's high, right? It looks high. So now we are confirming what diagnosis you guys think. Here's that. Oh yeah, where did I learn this? We learned it here. So what's your diagnosis for her? Yeah, right? That's zebra. It's not so scary when you have all of your class here to help you, right? So yeah, Theo, because of her history, her labs, her urine confirmed it. Great. So, what imaging do you want to order with that endocrinology referral? Where's the problem? In the body. And the problem is that it's treating excess FDs and norepinephrine. You could order MRI. Where? What organ are you looking at? Where's the problem? It's less than 6. That helps. Yeah, so Theo, excess. Yeah. So the last 2 lessons I talked about 1 gland a lot. They're little. 2 of them. Adrenals, yes. So adrenals, you can do an MRI or a CT. CT is a good one to do. Do I want a contrast CT or a non-contrast? Non-contrast. Now, an MRI plus the CT will catch this diagnosis vast, like 90% of the time. But again, non-contrast CT is what you want to do, but you could do an MRI as well, okay? Why don't we want to give this person contrast? You don't want to give them an episode, right? Because IV contrast, general anesthesia, stress, bending forward, spontaneous things can cause this, as well as all those factors, okay? All right, so what if the study is unremarkable and there were no masses? This is just extra credit for the group. What do you want to do? The MRI is normal too. Where else should I look? This one's tricky because it's, yeah, kind brain. Yeah, ectopic, yes, you're thinking the right one. I don't know tricky. So parietal ganglion, do you remember that? So those can be in the, chest CT to see, because you would do a chest CT. But that's not on the test. Let's just know that it's not always a pheo that can cause excess norepinephrine, okay, extra. All right, so we did a non-contrast CT, and it shows a mass on the left adrenal. And we already sent them to endo. Ooh, here we go. All right, so what medications? This person has a pheo. They're scheduled for surgery. They still have hypertension and tachycardia. What meds do you want to give to prevent like a hypertensive crisis? There's a specific, yeah.
I'm thinking alpha blockade.
Yes, alpha blockade. And what do you not? Okay, Brent. What do you do not give this person before the alpha blocker? Yeah, you give that after, right? Yeah, I know. Yeah. Okay. So what? So can I give him a calcium channel blocker?
Yes.
Yes, you can. So alpha or calcium, then the beta blocker, because we want to prevent what? Alpha blockade, hypertension, all that stuff, right? We want to prevent hypertensive crisis. Okay, you should probably know that. Because if I say know the order, it's probably important in life, not just for a year. Okay, any questions about that patient? Okay, pheo check, zebra check. All right, so Pat Benchar is a 7-year-old female. She presents for a routine sports physical. Over the past 3 years, she's experienced rapid somatic growth. Her mother reports a 6-month history of axillary and pubic hair development, as well as increased body odor, needing deodorant. Her mother is concerned and asks whether these changes are part of normal development. What do you think? Yes or no? Is this normal? Yeah, right. What do you think? No. I mean, technically, we all get that, for most of us. Eventually, right? It's that 7-year, right? And she's growing a lot. Yeah. Potentially not normal. Okay, so we review her record and her past medical history. Obstetric-wise, it's all normal, okay? You can read all that, but it's uncomplicated for mom and uncomplicated for baby. From 9 to 18 months of age, her growth tracked, so now we're looking at the growth charts, and they track if you have kids or if you, I know you haven't learned how to read growth charts yet, but it's just like a chart that shows if you're on par compared to other people your age. And so from 9 to 18 months of age, her growth tracked at the 95th percentile. So all that means is that she was a big baby, a big toddler, right? But it was on track for her. But by age 2.5, her height was equivalent to a 4-year-old. But maybe both parents are tall, so okay, so again, nothing was done at age 4. Mom also reports the development of facial acne around age 6, which notes was earlier than her older sister had experienced. Okay, this is a hard one. What's your differential? Think 2 to 3. We can do this as a group if you guys want. Gigantism, perfect. She's too young for acromegaly. What else? What's that really fun excess androgen? What's the name? Yes, say it a little louder. Congenital adrenal hyperplasia. So that's a good one, right? And then there could be some weird genetic disorder that we don't talk about in this class. So, physical exam. Her height today is consistent with the average. So remember, she's 7, but her height is on par with a 9-year-old, and her weight is also on par for almost a 9-year-old at 10 months, so almost 10. So she's a big 7-year-old. Remaining vital signs are within normal limits. She's well-developed, well-nourished, no acute stress. She appears tall for her age, but is well-proportioned and muscular. There's acne on her face. GU exam, there's presence of fine pubic hair. We haven't learned Tanner stages, but she's a Tanner stage 2. Mild clitoromegaly, and the neurologic exam is normal. So what is the primary problem of this patient? Think what's an excess? Yeah, oh, wait, yeah, kids. Yeah, IGF-1 could be for sure because of that. Yeah, then the sex and the androgens that we talked about that. So congenital, do you think it's classic or non-classic for the congenital adrenal hyperplasia? Classic or non-classic? So classic, you think baby? And they don't, yeah, so it's not. And then, yeah, so again, here's just a summary, more for the androgens. So again, we talk about this a lot next block, but increased, how the increased growth makes a difference. The secondary sexual characteristics is the androgens. These androgens can be derived from ovaries and adrenals. That's another topic. But anyway, there's just a little preview for what's to come. You don't need to know that for the test. So whatever slide 47 is for your information. Knowing what you know now, what labs would you order? So you already said one. IGF-1. Remember classic 17. Like you can I throw it? Oh, that was too short. I'm trying not to do that. Okay, there we go. Oh, that one. And my family will roast food and catch it in our mouth, and obviously I'm better at that than throwing candy apparently. Okay, so this is the last. So we did an LH and FSH, which you guys aren't expected to know, but then there's that 17 OAHP. So we checked that, and then we checked the testosterone. And we have, how do you interpret these results? Like, what do you see? What's happening? Yeah. Yep. Testosterone's also high, but don't worry, I'm not gonna, that's why these labs are a little more robust than you're going. But when androgens are in excess, testosterone will be excess too, okay? So also it's high, the hydroxy, progesterone, and testosterone. All right, so only if it's on less than 1, what do you think is the diagnosis with 17 hydroxy? Yeah, non-classic. Okay, there are 2 types, right? Classic and non-classic. We think this patient has classic because they're 7 and they aren't having like too many cortisol issues, but we would check that. How do the other ones present? How does that classic present? Yeah, they don't always make it because it's a significant deficiency of cortisol, right? These classic patients, they are still making some cortisol, so we don't actually notice the problem until pre-puberty or in puberty, right? Also, babies can have like ambiguous genitalia. They don't do well, okay? Yeah.
She's not classic, right?
No, she's just not classic.
Okay.
We're talking about classic. Yeah, good question. Yes, non-classic because of the age, and it's happening in that pre-puberty phase where androgens go up. So with that increased need in androgens, normally she's just having extra because the pathway is blocked because she has a mild enzyme deficiency. So we have excess of the 17 hydroxyprogesterone. Yes, so non-classic. But we just talked about classic for just a review of how we won't get that confused if it's ever a trust question. Okay, and then I answered this. Related to the deficiency, classic is a pretty much a full deficiency versus non-classic is a mild. So again, that's why they present later. Okay. Who do you want to refer this person to? Yeah, he's endocrine, right? I don't want to see this. I'm not managing this person. What is the treatment of this patient? This is for your information. Yeah, yep. Because remember, I'm not going to quiz you on the medicine, but oral contraceptives, and then we want to treat like the acne and the hirsutism and all of the things that happen, so you can do spironolactone and all that. But don't worry, that's all endo, not us. And then what's the goal of this, like this person? Would you think, just overall? Like, yeah, slow it down. We want to have her like normal growth, normal cycles when eventually that happens, all of that stuff. So again, this is managed by endo because you can't, you're giving a 7-year-old spironolactone and all of these things will be them. But again, we want to get them to, and then normal growth too. Okay. Yay, that one nobody likes. Peds. Sorry. Maybe we'll like it next block when it haunts you again. All right, so new patient, Glandy Lyon is a 27-year-old woman presents with depression, insomnia, a puffy face, trouble losing weight, and recent increase in facial hair. Her menses have been irregular since they resumed after the birth of her child. Okay, so she's 10 months postpartum. She's not breastfeeding. She's not taking any medications, denies illegal drug use or illicit drug use, tobacco, and alcohol. Okay, so we have a person with depression, insomnia, trouble losing weight, and increase in facial hair. What do you think is your, and she's postpartum, what's one of your differential diagnoses? It doesn't have to be endo, but it can be. You can't take the easy one.
No, this is postpartum.
Yeah,
Thyroiditis.
yeah, it could be postpartum thyroiditis. It could also be what? Postpartum depression can cause weird stuff. It could be any kind of thyroid disease, like her Cushing's because of the face. For sure, we don't really know. We need more information, right? So let's get more. Cool, I forgot it. Oh, missed that row. Okay. All right, so she did labs in the last few weeks prior to her visit. CBC is normal, CMP is normal, and she's not pregnant. So you're gonna go in and see this patient. So the tech got blood pressure is high, yeah. Heart rate's okay. BMI, I know we haven't gone through classifications. Do you think this is high or low? It's high. She's a bigger, so 31, so she's class 1 obesity. But she is not in acute distress, obese. Most of her weight appears to be in the abdomen and hip regions, so center. She also notes that that her face is puffy with an increased facial hair and a ruddy complexion. What do you think ruddy means? It's like red, right? No peripheral muscle wasting or striae, so you look at the abdomen. Which endocrine systems do you think is the primary problem? So when I'm thinking endocrine system, like what organ is an issue, do you think? Yeah, thyroid. What's another one? Pituitary, for sure. Pituitary causes a lot of this stuff, right? So think like Cushing's, right? Because of the hypertension of the face, and some of these things. Remember, they could have more than one. So the increased facial hair could be hirsutism, which we'll talk about next time. Suggests an increase in what hormone? So when we talked about, what do you think is excess if a female has facial hair? Testosterone, right? Androgens, for sure. We'll just say androgens for, we'll learn all the details of that soon. The depression and puffy face, what can that fit into?
Like for cortisol.
Cortisol, thyroid, what we already talked about. Yeah. And then what are the possible causes for hypertension in this patient? Cushing's, the thyroid disorders, right? We have lots of that. Maybe less acromegaly, maybe less pheo, but possible causes. Okay, good job. All right, so the combination of increased androgens, so this is like a summary slide, and cortisol and mineral corticoids would suggest adrenal stimulation by ACTH, right? If all three are up, we're gonna think ACTH. It's just gee whiz. And I think because this case was harder before. Depression and confusion with the puffy face could definitely be hypothyroidism, or it could just be depression. And then the serum electrolytes aren't really helpful for like that hyperaldosteronism, but Cushing, all of that stuff. So that's just like an expansion of what we already said. Okay, let's go back to our patient. 27-year-old female, depression, struggling with feeling depressed, insomnia, puffy face, facial hair, ruddy complexion, irregular menstrual cycles. She's obese. She's centrally obese. Hirsutism, just the male pattern facial hair. Puffy face. Oh, she's repeating it. Oh. Okay, anyway, sorry it's repetitive there. What initial lab test do you want to order to evaluate this patient? So right now we only have a CBC and a CMP. What else do you want to get on this patient? What's that? Yep. And what else? What about you? What else should we get? Besides, with the TSH, what else do we order? Yeah, T4. Maybe not T3 because they're, no, like, well, then I have to get okay, no, I didn't actually search for that. It's still that from Karen. And it's funny because I do this again and we talk about obesity and diabetes and I could bring fruit. But anyway, okay, so initial labs, so we have a TSH and a T4. What else? With like thinking menstrual regularities, what would you, what else would you order? Or Cushing's? Yeah, dexamethasone suppression, because you're thinking like hypercortisol, right? Yeah, it was. What's another hormone that you could check that can affect menstrual cycles? T, but we haven't learned that yet. But I like it. Prolactin. So prolactin. I'm not thinking this is prolactin, but you can absolutely check prolactin too. Okay. So here are your labs. TSH, T3, and T4 are up there. We have prolactin. LH and FSH, you guys know how to read those next time. And we have a 24-hour urine cortisol. Man, this, yeah, got quite real compliant patient. So, how do you interpret what do you see on these labs? Yeah, that urine cortisol is high, right? Then at the top, the dexamethasone, remember we give them steroids at 11 o'clock at night, and then we have them do morning, we check the morning cortisol, because cortisol is pulsatile, right? We can't just check it when it's in excess. Is that high or low? It's high. Okay, so what do those two labs indicate? Not a diagnosis, but what do they indicate? High what? High cortisol, hypercortisolism. Okay, so do we know that this person has Cushing's disease or Cushing syndrome yet? No, why, right? Because they present the same. So what additional lab should we order to help me point to, is this Cushing disease? Is this Cushing syndrome? Lab, what extra lab? ACTH, perfect. ACTH is what we want to get. I promise I'm not like a panda. You're eating all the candy. Okay, so yes, ACTH. And we have ACTH, is this high or low? High, right? Okay, so if ACTH is high as a group, what do you think is the most likely diagnosis?
Disease, dome.
Disease, no, because it's ACTH dependent. That cortisol is high because the ACTH is high, and it's telling the adrenals to produce extra, right? Is that ACTH dependent? Let's stop here and maybe one more. Here's this other beautiful slide that I think my next question, which might be. Okay, what's the next step in this person? So you know today we think Cushing disease. What, and where is Cushing disease? Where's the problem? In the dome. So we're going to order. Now you can get your MRI. Perfect. Okay, so now we get the MRI. And it confirms a pituitary adenoma. And what Well, okay, we can push, we have like 3 minutes, maybe we can finish this case. What treatment does Endo recommend for anterior pituitary adenoma secreting excess cortisol? What do we treat it with? That back row really like.
Taking it out.
How are we gonna take it out?
Ripping it out.
We go through, what do we do? What's that surgery called? Transnodal resection, right, through the nose, super gross. They did it and it was Dr. Cushing who like formalized it. Yeah, so it's surgery, right?
Yes.
Okay, know that probably. Oh yeah. Oh yeah, because it's Cushing disease, and so way back in at the beginning of lesson 3, when we compare CT or MRI is just pretty picture. It's like really, because how big is that CT? It's itty bitty. So you can order a CT, but the MRI is going to be that hot. It just gets that. That's a really good question. But yeah, it's MRI. Okay, so they're gonna recommend surgery. What do you give? I'm gonna remove this Cushing disease-causing adenoma. What do I need to give them after I remove it? Yeah, cortisol. Let me say that. Cortisol, right? Because they have excess cortisol right now, and we're taking that adenoma out, and the body's going to tank. So we need to make sure we give them some additional cortisol. What is a complication that can result? This could be extra credit, or not. It's not extra credit. What? This is a group 1. What is a complication from a pituitary surgery? Endo complication.
Yeah,
Pituitary related. Close. Think lesson 2. SIADH and diabetes insipidus. Yeah, usually diabetes insipidus will happen first, and it's temporary, and then they go into SIADH, and that's usually also temporary. My clicker. Okay. All right, that's good. We can have a break, and we only have 2 more, and they're hard, so we'll come back at the top of the hour. Harder. We have a couple of rows to go through, and then once we get everybody a great chance to open their mouth and say something, then then we'll do group wise. Okay, so adrenal rush is a 40 or adrenal rush. In my head, it was like adrenaline. Adrenal. Anyway. All right, 40-year-old woman presents with a 6-month history of increasing fatigue. What's your initial differential for this person, just based on fatigue?
Cancer.
Hypo. Yes, cancer, for sure. Hopefully not. Yeah, Addison's can be fatigue. Great job. Perimenopause, all of the things, right? So what system? So Endo, what's another system? Obviously, heme is cancer.
Neuro.
What's another system? Cardio, right? Cardio things can cause fatigue. If I'm pregnant, can a 41-year-old female be pregnant?
Yes.
Yeah. So if I'm pregnant and could be tired, maybe I would know by 6 months, but again, you hear those stories. Okay, so good job. All right, so we got more. During this time, she's had unintentional weight loss of 25 pounds. She's noted joint pains, muscle weakness, mild nausea, and diarrhea. This is definitely an endo case, right? A cluster of symptoms. She's noticed some irritability and feeling on edge more than previously. She has not had a menstrual cycle for 3 months. Whew. Okay, what's your differential? And it can be endo-y, ideally. What do you guys think? What's the differential? What could cause this? Fatigue and weight loss. Joint Addison's. Yeah. What else? Maybe a thyroid, hyper, because of the weight loss. It doesn't, and the diarrhea, right? Pregnancy, no, less now. Weight loss, right? Not concerned about that. All right, let's get a little more information. So she's 5'4", 102 pounds. Heart rate's okay. Blood pressure, 100/78, initial thoughts. Pretty low. I guarantee there are people in this room who that's their normal blood pressure, right? So we would obviously want to compare. We're gonna do orthostatics, and those were normal. Her thyroid gland is diffusely enlarged, and her bowel sounds are hyperactive. So what endocrine disorders are you thinking? With a goiter, does she have fatigue, diarrhea, irritability? What are you thinking? What's your differential, thyroid-wise, or endo-wise? What's that? Yeah, so thyroid, as I said it, sorry. And then what's another thing that could be a problem? Causes hypo, we've already said it. Outside of the thyroid, think big. Thyroid problem, check. What's another problem? What's another primary target? What's that? Pituitary, perfect. What's one more? Primary organ that produces something that causes someone to be hypertensive. Adrenals, yes, good job. Okay. What would you consider if this person comes to you and is like, I've lost 25 pounds in 3 months and I'm not trying? What do you worry about? Yeah, malignancy, right? That's always in the back of your mind. Even in endo, right? We have examples where endo or cancer is the cause of some of this stuff, right? Okay, so what conditions should we consider that causes amenorrhea? Obviously pregnancy, not as concerned because of the weight loss, but what are other endocrine things that can cause menstrual irregularities? Prolactinoma, yeah. Thyroid we already talked about. Adrenal insufficiency can cause weight loss or irregular cycles. Hyper and hypo can cause irregular cycles. Okay. What's the initial test you order to evaluate the patient? So labs and rads, what do you want to do for this first? Yeah, and T4, yeah. Do we need a T? Maybe a T3, you could consider it, but for sure you can consider a T3. I wouldn't be opposed to it. What else? What other labs do we want to order for this person? Or imaging, or stuff we can do in clinic. What do you want to do for this person? And you're working in our clinic. What can we order? So not a CT yet, because we don't have our labs back, because it's endo. EKG, yeah, we can do an EKG. What other labs? For your other pregnant. Let's do the HCG, even though I don't think she's pregnant, but she could be pregnant at the same time. And let's look at those labs. So CBC showed anemia. Her CMP, her sodium is a little low. Potassium is a little high. Prolactin is normal. Okay, I got one normal. TSH is high. T4 is a little low. She's not pregnant. UA is fine. Chest X-ray and EKG are normal. Okay. So, what symptoms correlate with the TSH level? So here's a picture. Oh, I'm highlighting it. So let me go back so I don't give you the answer. What of her symptoms correlate with that? The TSH and low T4, the high TSH, low T4. Yeah, what else? Menstrual cycle, probably, right, guys? If you look at her exam, we have a diffusely enlarged thyroid gland and some hyperactive bowel sounds. So the hyperactive bowel sounds, usually we see constipation, but that's not with hypothyroidism, but the hyperactive bowel sounds don't tell me a lot, right? I need a little bit more. Okay, does that make sense? Signs and symptoms why this person has hypothyroidism? Okay, here they are. Okay. What other lab results might contribute to the patient's fatigue? This could be a group answer. So what other things can cause this person to feel tired? Anemia, right? I know that's next semester, but for sure, yes, anemia. Okay, so here we look at her. Let's do a recap. So fatigue, joint pain, muscle weakness. She's feeling on edge. That doesn't, or on edge, excuse me. That doesn't really fit the hypothyroid, right? Hypothyroid, the metabolic hormone is turned down, but she could feel on edge for other things. The weight loss doesn't really fit that hypothyroid patient, right? Usually they're either weight neutral or weight gain. GI symptoms, again, we talked about constipation more than diarrhea. Hypotension does not fit hypothyroidism either, right? It could be, but again, it doesn't really fit that classic picture. Goiter does, and then here's our labs. Okay, so we have this summary. What other labs would you want to order to help you figure out why this person is hypotensive? And it also correlates with the weight loss. So electrolytes, we have her sodium is low and potassium is high. That's the only one. So what other endo thing causes hypotension? We talked about it over there. Addison's, yes, so what lab do we order? Yeah, before that, and with that, sorry, or with it. Sorry, with it, not before. What is overall low in a person with Addison's? Cortisol, yeah. So this is the time, sweet, I don't have to do a suppression test initially. I can just directly order the cortisol, okay, and the ACTH. So let's do that. All right, how do you interpret these results? Yeah, ACTH is high. What do you think of her cortisol? Yeah, it's low, right? Okay, so what should we do now? So we're thinking hypothyroidism, maybe some damn adrenal insufficiency. Where should I send this patient? Yeah, get some scans. Where else? Like, who's hard to get into? Endo, yeah, this person's going to endo because they have a thyroid thing and potentially low cortisol, so yeah, absolutely, we're gonna send them to endo. So what do you think endo, what did they do to confirm Addison's? What's that? But it's, yeah, I know. Yeah, cositropin, or the ACTH stimulation test, right? So we kind of stimulate it. What is the diagnosis? And is it primary or secondary? Great. So we have, let's say the cositropin was low. ACTH is is high. Cortisol is low. What do you think? There's two options. What do you think this person has? We know hypothyroidism is on there. What else? Based on the low cortisol. Yeah, Addison's and high ACTH. So understand that feedback loop too. Like you're on the spot and that was hard. But primary or secondary? Primary because, great job. Primary because the autoimmune caused the adrenals to be atrophied and they are not working. Okay. And what is the, okay, I already answered this. What's the most likely cause of this? Look at stuff. It's hot in here. What is the most likely cause, underlying cause of Addison's? Is it infection? Is it autoimmune? Good job. Yeah, perfect. All right, so they do additional tests and they see that it is, they do some antibody tests, but they do TB and histoplasm, and that's because there's a small percentage of Addison's that's not caused by autoimmune. Do I care about that? No, I care about the 90%, right? Okay. How do you interpret these? Obviously, just confirms it's autoimmune. Primary adrenal insufficiency and likely Hashimoto's thyroiditis. Okay. How should this patient be treated? So we have two conditions. Pick one. Addison's or hypothyroidism. How do you want to treat them? Yeah, you give them what they're missing. Perfect. And then what we know how we treat. We know how we treat hypothyroidism. We talked about that, levothyroxine, all the important things. What education regarding cortisol do we need to tell this patient? What are key things that we need to tell a patient who we're treating? If you're going to say, when do we need cortisol in our body? When do we need it normally? Yeah, when you're sick, stress, like a surgery causes stress, infection causes stress, right? So sick day stuff, right? Motor vehicle accident, all of that stuff. What emergency thing does this patient have? Would you give this person, because life happens, stress and sickness happens unexpectedly? What do we give this person? So, to prevent an emergency. So what's that? Prevent as well and fix if needed. So they kind of do both. The bracelet, yeah, give me cortisol or watch me die, right? That it's funny, but it's accurate and dark, and I like it. Yes, so give that. So you're gonna do the little kit. You're gonna maybe have you can give them like IV cortisone. Teach who should know what to watch for. Family and patient. Perfect. Yeah. So you want to make sure, because you might not notice that you're going low. When we talk about diabetes, you'll learn why people don't know they're going low. Too. But great job.
I have a question about
Yes.
that. So do you kind of hold it like an EpiPen? Is there a way like, hey, maybe you're going under like that emergent situation? Do you need to go to the hospital for that, or is there like a way?
You would do it if you're at home. You would just give the injection. You would teach them to give it, and it's not as cool as an EpiPen. Same with glucagon. Glucagon's really annoying. It's a powder, and it's all this whole thing. But yeah,
Okay.
yeah, it's. And I thought I had one more patient. How should we put this to? Front row, our AV person right here. Okay, shoot. Do you know I hate beans? Like when I was in PA school, I hated this stuff. So thank you. I was not a hand raiser. Then when you get old, you just stop caring. But yeah, so great job. Thank you. Next time I'll just hand out the candy and you can pass it around because you're all going to participate. Any topic that you're just like, ugh, I'm not quite there yet. I know everyone's thinking asthma, but after we go through all of this stuff, anything like standing out? Okay, secondary adrenal insufficiency. Okay, what's the most common cause for that? Secondary adrenal insufficiency, what happens is, well, where's the problem with secondary adrenal insufficiency?
It's not the adrenals,
Right.
it's like the
Pituitary, right. What's the most common cause? Is it the body or is it your PA, doctor, NP? What that causes it? Like most common causes, not Addison, secondary, so low cortisol. What's the most common? Not the body. We do it by we give them steroids. So most of the common cause for secondary adrenal insufficiency is us. We're giving them steroids, all of that stuff. The thing I just talked about this with somebody. Remember, so with primary, you have autoimmune, the adrenals fail, and they get atrophied, so they no longer produce cortisol, right? With secondary, I'm giving the person cortisol, so what do those adrenals get to do? Do they need to work? Well, they kind of get to take a nap, right? So they get to kind of take a nap because I'm giving the person cortisol, okay? So when I do the cosentropin stimulation test, and I give somebody whose adrenals technically work just fine, and I give them ACTH, what should happen? If I give someone ACTH, what should adrenals do? Yeah, they should. But when you look at the slide, cosentropin stimulation test is low with someone with secondary adrenal insufficiency. And that's because the adrenals are napping. Okay, so it confirms that there's an adrenal insufficiency, but it doesn't point to where the problem is. ACTH does, okay? ACTH again. So, does that make sense? So, and again, if you can also look, there's a slide where we talk about secondary adrenal insufficiency, and we talk about people who are on steroids and then just stop. Remember, the adrenals have been napping, so it takes a long time for the pituitary to start producing more ACTH, for then by default the adrenals to produce cortisol. Okay, so think napping, adrenals. Okay. Any other questions? Okay. Good job. Good luck on Friday. And I'm available by text or phone call. If you have questions, I will answer.
Thank you, ma'am.